Ellos tienen ahí un centro de referencia para patología hematolinfoide, se organiza muy bien en Alemania y a ellos les refieren casos de patología linfoide y trabajan muy bien los casos. Y tienen mucho interés, como nosotros, en investigar los marcadores moleculares y cómo mejorar el diagnóstico molecular de los linfomas en la práctica clínica. Además, es catedrático de patología y miembro de las sociedades europeas de hematopatología y de patología de médula ósea. Entonces, estamos encantados de que hayas aceptado la invitación de venir, Falco, y por favor...
Pues buenos días a todos. Muchas gracias a Santiago por invitarme a esta hermosa ciudad de Santander y estoy muy feliz de estar aquí, pero creo que es mejor para todos ustedes y para mí también de seguir en inglés. So my talk today is about molecular studies, and I'm going to show you how we do translational research in lymphoma and how much of this we move actually rapidly into molecular diagnostics. So what I'm going to talk about is both the rationale and indications for molecular testing and lymphoproliferations. I'm going to talk a little bit about NGS-based clonality because I think that's always and still a very important method. I'm going to talk about mutational analysis, relatively little about gene expression profiling, a little bit about the new classifications, as you know, and all the clinicians will be happy about that. We have now 2 instead of 1 classification. We hope that this topic is resolved soon. And also going to perhaps try to see into the future, which is always very difficult, how molecular diagnostics in lymphoma is going to develop, and why morphology, and I'm from the heart a morphologist, even though I have worked in molecular biology all my professional life, why morphology is still important. So how do we diagnose lymphomas today? We all know we get a biopsy, we do morphology, we do immunohistochemistry, perhaps in situ hybridization, FISH, and we do some clonality, so that's the conventional way. And what's very important to all the clinicians here, we need clinical information for these cases. And perhaps in the future we will do more by looking more at the genetic alterations of lymphoma, at the gene expression profile, to get molecular groups as they have been designed, for example, for diffuse large B-cell lymphoma, to get a more personalized or more targeted therapy. This all is possible because we have moved technologically from few or 1 target at a time, like clonality by gene scan, FISH, sequencing by Sanger, and now we can do NGS. We can look at multiple targets at the same time. We can do whole exome, whole genome sequencing, even though I think that's for most purposes not really useful, especially in diagnostics. We can do gene expression profiling, array CGH, and other techniques. So, but if we take a look from the clinical side, what are the indications actually for molecular testing? Well, first, we all pathologists, we love the core needle biopsies. The smaller the better. It's really, I think, something which will bring down the quality of diagnostics. So I ask you, especially if in difficult cases, please go ahead and try an excisional biopsy. But anyway, we have to deal with these samples. So we have core needle biopsies, we have small biopsies from other sites, we have extranodal infiltrates, subtle bone marrow infiltrations. And we usually use molecular techniques a lot more in T-cell than in B-cell lymphomas. We also need to look at recurrences or transformations. As you know, a transformation in CLL is something which is a lot worse than a secondary unrelated DLBCL in a patient with CLL. So we have to look at clonal relationship, for example. And of course, if we want to subtype lymphomas, then we need more than just 1 marker. And also, if we look at prognostic or predictive markers, we would need more information. So we have moved from clonality and from single or few targets like rearrangements or single mutations like MYD88 or BRAF to multiple targets, mutational profiling, CNA profiling, even methylation and gene expression profiles, even though there are different levels in which we use them in clinical practice. I'm going to talk a little bit about B and T cell clonality because even though it's a very old technique, it's crucial to the understanding of lymphoma, and in my opinion, and after doing many years of molecular diagnostics, it's actually the most difficult test to interpret. You all know that the genes in T cells and B cells get rearranged. They're like different cards of a train and put together to form the antigen T cell or B cell receptor. And this all not only serves like identification of a lymphoma because it shows that they all are derived from a single cell, and we can use it as a marker, clonality as a marker, but it also tells us about the history of the lymphoma, as I'm going to show. And we all know that these rearrangements are, which take place only in B and T cells, the only genetic alterations which take place in somatic cells, they are actually a risk factor for lymphoma. So clonality may seem old-fashioned, and we all probably use this technique, the gene scan technique. We can tell something about lineage assignment, clonal relationship, stage of maturation in B-cell lymphomas, because we can look at somatic hypermutation, and we can use it as an MRD test to track a clonal population. And it also tells us something about the biological features. So we all know that, but we only can use gene scan or heteroduplex if we don't need sequence information. But there are a lot more things which we can learn about T and B cell receptors, but for that we need precise sequence information. And just to tell you that we are now moving from gene scan to NGS-based clonality, why that's important. So this is a clinical case, a B-cell lymphoma which lost CD20 due to treatment with rituximab, and the patient relapsed with the CNS, and the question was, is the testicular lymphoma related to the CNS lymphoma? And if you look at the clonality analysis, you say, okay, this is clearly unrelated. You have different product sizes. So, but are we sure about that? So we take a look at the NGS-based sequences, and you see the sequence of the amino acids is exactly the same in both lymphomas, only that you have a 9 base per insertion here, because somatic hypermutation, which is ongoing in some lymphomas, actually not only creates point mutations, but can create insertions and deletions as well. So these two different products are actually from the same lymphoma. It's just an evidence of clonal evolution of the lymphoma. And that's important. So that's one reason why we can use it. But we can use it for many other things as well. BGJ usage, I will talk about that, somatic hypermutation, evidence of antigen selection, stereotypic B-cell receptors, which are important in CLL, MRD detection, and ongoing somatic hypermutation as evidence of clonal evolution. Just to give you a couple of examples, this is a study which we did together with Dutch colleagues on Hodgkin lymphoma recurrences. And actually in Hodgkin lymphoma, you can easily detect in most cases the clone. We know these are B-cell lymphomas by now. And if you look at recurrences, you can see that about 15% of cases of especially late recurrences were clonally unrelated, which means this is a secondary disease. And if you combine this with mutational profiling, you can also see the clonal evolution. We did some work together with a medical student at that time, looking at patients with DLBCL and searching for in situ follicular neoplasias in reactive lymphoid tissues. And we could show that actually if you have a de novo DLBCL and you have an in situ follicular lesion, which is a pre-neoplastic lesion in these patients, that the DLBCL is derived from this lymphoma. They're always clonally related. And looking at the sequence, you see that you have many subclones in the in situ follicular lymphoma, and if you have a follicular lymphoma in between also. But once you have an aggressive lymphoma, one clone really jumps out because this is driven by additional mutations. And we can see that, for example, if you relate it follicular and diffuse large B-cell lymphoma, that you have something like branching evolution. They come from the same root, but they have different mutations, which are called private mutations. And we also can look at, it gives us also prognostic information. In CLL, we know that if you have unmutated genes, these patients do worse than those with mutated IGH genes, even if they have some high-risk feature like T1117P, where TP53 sits. And we know now that CLL are subtyped according to the stereotyped receptors of the immunoglobulin genes. And we actually know that many of the CLL, which don't have a mutation which can be called a driver mutation, actually is driven by the B-cell receptor signaling. So the B-cell receptor itself is the oncogenic driver in this so-called driverless CLL. So using NGS, we get a lot more information, but it doesn't make things easier. So this is how we calculate, how we look at clonality if we use NGS-based clonality. It's a paper from Euroclonality Consortium. And this software sort of recreates a gene scan. And you can see, okay, this is easy. This is clonal. This is polyclonal. Everything which is gray is less than 0.1% of sequences. But if you look at this, here you have a clone. Here you don't have a clone, even though this peak is smaller than this one. But it depends on the ratio of the dominant clone with the other clone. So here you have a minor clone. And here you just have few B cells, which gives you this pattern of few rearrangements. So interpretation gets more difficult, but you get a lot more information. But still, to know what is clonal, and this is something which you always think, oh, that's easy, yeah? It's either it's clonal or it's not clonal. But if you look at this, these are 4 bone marrow biopsies of a patient with TLGL proliferation. You know, that's a common clinical question. Patient with neutropenia, you are asked, do you have a TLGL leukemia in the bone marrow? We do clonality, we always do it by NGS, and you see we have 5 different clones here, which sort of all are about 3 to 5%, they oscillate, so you have an oligoclonal proliferation of cytotoxic T cells here, but you don't have a dominant clone which would define a TLGL leukemia. So you get a lot more information out of that, and we know that this is something, a phenomenon which we frequently see in autoimmune disorders. TLGL is associated, for example, with rheumatoid arthritis and other disorders. I'm not going to go through this, but we have developed an algorithm which lets you decide if you have an NGS-based clonality and you don't have a clear-cut result, how to deal with that and how to arrive at a conclusion. So this was just a couple of words about clonality, but I think you're all interested to hear about mutational profiling. And we can do a lot with it, of course, subtyping, B-cell versus T-cell lymphoma, etc. And the question is what to test, how much to test, and how to test. So what's important, and this we should always keep in mind, if we are not talking about research, but about diagnostics, is what's the relevance? This is a clinical relevance score, which is based on diagnostic, prognostic, and theranostic interest. And so you should be here, and then you have to do it. You have to do the study. So what are the indications today for genetic testing in B-cell lymphomas? So we have diagnostic markers like BRAF in hairy cell leukemia, even though we can do it by immunostaining as well. We have MYD88 mutations in LPL. We have mutations in mantle cell lymphoma translocations. We have prognostic markers, especially TP53. And we have predictive markers like CXCR4 in LPL, which predicts lack of response to ibrutinib therapy. So we have different targets, and the question is how should we test? And you have to look at turnaround time, at cost, at sensitivity, and at clinical impact. So you can't look by sequencing with Sanger at MYD88 mutation or CXCR4 mutation in the bone marrow, because the test is not sensitive enough. So you will need to test something else, but you don't probably need a 50-gene NGS panel. You can do another specific PCR. So this is something which you have to discuss also with the financial offices of your institution. But if we look at small B-cell lymphomas, single markers usually are not enough. If you look here, MYD88 is a prototypic marker, but we find it not only in LPL, we find it in some large cell lymphomas, we find it in some nodal marginal zone lymphomas. And even BRAF, which we all know as the defining marker of hairy cell leukemia, well, BRAF has been found in a small percentage in multiple myeloma, in nodal marginal zone lymphoma, etc. So it's always about the context. Yeah? It's always about the context. And the next question is, we have seen a change now in classifications. What is the impact of the new classifications? With that, I'm going to give you a case study. So this is the MRT scan of a patient with exophthalmos, and you see the mass here, which was biopsied. So you would say, oh, classical adnexal orbital mold lymphoma. Well, you see plasmacytic differentiation and lymphocytic differentiation, and you stain, it's kappa IgM restricted. So IgM in mold lymphoma is something you don't want to see. So you do mutational profiling, you have MYD88 mutation, and the patient had bone marrow involvement and IgM paraproteinemia. So this was a lymphoplasmacytic lymphoma Waldenström with primary manifestation in the eye. Yeah? So this is something which shows you how you need to put the things together in context. A common lymphoma is follicular lymphoma. As you may know, there is some discussion about whether follicular lymphoma 3B is a follicular lymphoma or should be called differently, but I'm not going into this. But this is the difficult group. We have cases where we can't say it's grade 3A or 3B. WHO has gotten rid of classification of grading altogether, but I think it's still important. And then you can use molecular markers, potentially NGS, and FISH and other markers, immunophenotypic markers, to say, okay, this lymphoma, I don't know how to grade it, but it probably belongs to the grade 3B group rather than grade 3A group. And what about the role of molecular profiling in follicular lymphoma? You probably have all heard about the M7 FLIPI, which was designed to give a molecular risk stratification on top of the FLIPI, which is used by clinicians to say whether a patient has a high risk for transformation. But the problem is, if you look at the M7 FLIPI and you have your novel therapy, then the prognostic marker, the prognostic impact of this M7 FLIPI is gone. And this is something which I also want you to recognize. All these prognostic tools, if they are molecularly based, are strongly influenced by therapy. And so we have a lot of information about follicular lymphoma, what mutations there are. We know there are especially CREPP and other mutations in methylation, with changes in epigenetic regulators. But EZH2 is something which we are sometimes asked to do because tazemetostat is an inhibitor of EZH2, and patients which have this mutation have a better response than those with wild-type follicular lymphoma. But one of the clinical big questions is which patient is at risk for progression and transformation. And there is a new work out, relatively new work out from Vancouver, which have shown that by using genetic profiling, they actually could divide follicular lymphoma in those which were called constrained, which means they will stay follicular lymphomas. They won't progress. And they have the so-called DLBCL-like follicular lymphomas, which have a high risk of progression or transformation to DLBCL. And what's interesting, and that's why I referred to the diagnostic, to the discussion whether we should do grading or not. We know it's not perfect, but if you look at the grading in these two groups, you see that only 5% of grade 1-2 follicular lymphomas belong to this DLBCL-like group, whereas much more belong to the grade 3A. So if you look at grade 3A cases, 40% of those were in the so-called pre-transformation group, versus only 10% in the grade 1-2 group. So grading still tells us something, but it's not perfect. Follicular lymphoma, however, we have worked a lot, our group has worked a lot on follicular lymphoma which do not belong to the conventional BCL2 rearranged follicular lymphoma. These are the special subtypes. We have worked on pediatric type follicular lymphoma and the BCL2 rearranged CD23 positive follicular lymphomas. They are now recognized as a specific entity in the ICC classification. They are characterized by STAT6 mutations, and we are currently working on further delineating these lymphomas, which were first described by the Würzburg group. These are patients which are very typical. These are mostly or majority females, and they have a large single lymph node in the inguinal region with a diffuse growth pattern, usually stage 1, 2, so you really can discern them also clinically and can almost make clinically the diagnosis. It might be this type of lymphoma. Pediatric type follicular lymphoma, I think, is an example of how important it is to really define an entity properly, because if you are a pediatric oncologist or hematologist, you know everything which has the term lymphoma on it in children is treated aggressively. And this was also done with these pediatric type follicular lymphomas initially, until one realized that these behave very indolent. You cut out the lymph node, they are usually stage 1, the patient doesn't need any treatment, so probably it's better to call it lymphoproliferative disorder rather than lymphoma. But anyway, these are clonal disorders, they have a characteristic morphology, and they have a characteristic mutational profile which is completely different from follicular lymphoma in adults. And we now see these cases sometimes also in patients in young adults, 20, 30 years, up to 40 years. And this is very important because you look at the case, say, okay, this looks like pediatric type follicular lymphoma, you make the mutational profiling, and you can tell the clinician, no chemotherapy, no therapy needed, just excise the lymph node, and that's it. A new entity which was recognized in both classifications is large B-cell lymphoma with IRF4 rearrangement, which is also a usually localized disease, follicular or diffuse, frequently manifesting in the tonsil or in the GI tract. These are rare cases, but again, this is an entity. They have IRF4 rearrangements, and they have IRF4 mutations. These patients do very well with conventional therapy, so they need therapy, but they do very well. So it's important to recognize these. And as pathologists, we can suspect it if we have a triple positivity for CD10, BCL6, and MUM1. A couple of words about aggressive B-cell lymphomas, because that's an area with a lot of controversy from my understanding, because morphology, so which one is the Burkitt lymphoma? Yeah, probably this one. Somebody will say, yeah, perhaps this one. So it is difficult. Morphology is not perfect. So we have defined new entities like the 11q, which was previously called Burkitt-like lymphoma with 11q aberration. Here you need FISH or you need a CNV assay to identify this lymphoma because, as you can see from this paper, from a workshop, these are morphologically hard to grasp. Frequently, they look like Burkitt lymphoma and they have these typical starry sky macrophages, but they don't express MYC and they don't show MYC rearrangement. So this is something which needs to be defined out from these. You all are probably aware of this graph from the blood paper, which shows what tests we need to make. So we basically have to do FISH analysis on all of them, and you probably should do 11q and IRF4 in these cases as well, especially if morphology and phenotype fits. But we have been actually doing a lot more in research. This paper is already more than 25 years old, the Ashali-Sadeh paper on gene expression profiling DLBCL. But still, we're doing the immunohistochemistry subtyping in ABC versus GCB, but it's not mandatory, and we still don't do gene expression profiling. Why we don't do that? Well, because the outcome is not as in this paper. We know from many studies, from Germany, for example, that ABC versus GCB doesn't really separate out prognostically, because we know that DLBCL NOS is actually much more complex. You have many different groups. This is the so-called LymphGen classifier. The problem with this classifier, and we use it in daily diagnostics as well, is that 40% of cases you can't classify. They're either in a mixed group or they cannot be classified properly. And so both WHO and ICC decided, well, molecular profiling these groups, whether you call it MCD or cluster 5, that depends on which papers you read. You should read all of them. But this is not prime time for diagnostics yet. So we can use it, but it's not something which really will guide your decision. But actually, it starts to evolve, especially the MCD group is something which clinicians want to know more and more now. And I'll give you an example which we use in daily practice, which is vitreoretinal lymphoma, which is something very rare. But we see a lot of those, and now we have a big multicentric study in Germany running, which is focused to Tübingen, and so we see like 3 to 4 vitreoretinal lymphomas or cases with this diagnosis per week, so we have a lot of those. And these are of MCD type. They have a characteristic mutational profile, and the problem is if you make a vitreous aspirate, you can't take a biopsy from the eye that easily. The cytology is poor, clonality doesn't work, flow cytometry doesn't work, cytology sensitivity is 45 to 60%. So we actually decided more than 10 years ago, what can we do about that? And we started doing mutational profiling. First, we looked only at MYD88 because that's the most frequent mutation. And then we designed a small panel, and we use this now. And even as a morphologist, I have to say, looking at these cases, and the same is true for the CSF, for the cerebrospinal fluid, molecular is a lot better than morphology in this specific area, because we get 95% of cases, and if you look at CDKN2A deletions in addition, 100% of lymphomas will be found with this tiny small panel, which can be used in the CSF and can be used in the vitreous. But we have gone on from this. I'm not going to talk a lot about peripheral T-cell lymphomas. Here, molecular diagnostic is still in its infancy because we don't really have good markers for most of these diseases. We don't really have therapeutic targets that much. We have very few mutations which really are high frequency. And nodal peripheral T-cell lymphomas, this is the scheme from the ICC publication, mainly based on immunohistochemistry. CD4 considered TFH lymphomas, angioimmunoblastic T-cell lymphoma. And this is something where we do a lot of small-scale NGS to detect the most common mutations. And you can do a similar subtyping, immunohistochemical or gene expression subtyping of nodal peripheral T-cell lymphoma as we do it for DLBCL. We have done some work on TFH lymphomas. This is just to show you these are the most common mutations in all the studies, and the values are actually quite comparable. It's IDH2, RHO-A, TET2, and DMT3A. So we have 80% of cases about have TET2 mutations, and DMT3A and TET2, for those of you who work with myeloid disorders, they know, okay, this sounds like clonal hematopoiesis. And we also know that clones, T-cell clones, can change. And it has been published by several groups now that if you look at the bone marrow of these patients, TET2 and DMT3A mutations, which you find in the lymphoma, you already find in a non-involved bone marrow at very high allelic frequency, which means these lymphomas are derived from clonal hematopoiesis. And that's why it's not surprising that up to 20% of patients with angioimmunoblastic T-cell lymphoma show actually a coexistent myeloid disorder, especially CMML or MDS. And we also did a comparison here of looking at clonality by NGS and mutations. And you see, this is a case with bone marrow biopsy before and after treatment. And after treatment, we still can pick up the clone 1.3% with NGS-based profiling, molecular NGS clonality analysis. And we find the mutations, the TET2 and DMT3A mutations, always in the bone marrow, or almost always in 80%. But the RHO-A and IDH2 mutations, they disappear, which shows you we have clonal hematopoiesis here on which this lymphoma is based. And we recently published a nice case which shows the potential of this clonal hematopoiesis. A patient which first presented with a cytotoxic T-cell lymphoma, then with an angioimmunoblastic T-cell lymphoma. And he had two different sequences shown here by NGS-based clonality, but he had some joint mutations, some shared mutations, and many private mutations, which shows that these two different lymphomas were clonally unrelated based on T-cell receptor, but they were clonally related based on their common origin from clonal hematopoiesis. So this all sounds very complicated. So can we reduce the complexity of molecular testing in lymphoma? We have to do FISH. We have to do mutational profiling. We have to do clonality. And actually, that's a very nice paper which comes from Belfast, and this assay is really useful. This is a one-stop shopping, which means you do an NGS panel which includes B and T cell clonality, the most important mutations in lymphoma, and the most important translocation in lymphoma. So you don't have to mess around with FISH, you don't have around with clonality, you can do one assay. We are currently testing that, and it actually works very well. And a larger second version of this protocol is coming up. The last couple of minutes, I think I went through fast, so we will have plenty of time for discussions. I'm going to spend about liquid biopsy. As I told you, I'm a morphologist by heart, but I think we cannot sort of close our eyes in front of liquid biopsy. You can do a lot of things in liquid biopsy. You can look at mutations, at rearrangements, at CNVs even. You can look so-called fragmentomics, metallomics, at extracellular vesicles, so you can do a lot with that. And actually in lymphoma, it has been shown that in aggressive lymphomas, this doesn't apply to many large small B-cell lymphomas. This doesn't apply to T-cell lymphomas, but it's very good for Hodgkin lymphoma. You actually can use liquid biopsy, which means cell-free DNA, which you do with specific protocols with so-called unique molecular barcoding for the NGS product. You actually get very good results in follow-up, and we know that if you treat a patient with Hodgkin lymphoma, DLBCL, and the cell-free DNA, the mutations drop off in the peripheral blood, this patient is going to do good. If the mutations remain to be detected, this patient is going to have a relapse or refractory disease. And that's been shown in a lot of studies. And I think that actually cell-free DNA as a tool to follow up might complement or even replace interim PET, which we do in aggressive lymphomas, for example. So I think that's an important technique. And what we also use, if we know a mutation, which is a core mutation like MYD88 in cerebrospinal fluid, we use the digital PCR because we reach a sensitivity which is even better than NGS-based mutation detection. And I'm going to give you an example because we are doing liquid biopsy not for lymphomas, but for breast cancer and non-small cell lung cancer in the peripheral blood, but we do a lot of liquid biopsy in other fluids, especially the cerebrospinal fluid and the vitreous. And this is the study from this project, and you see that if you look at the supernatant, we actually have more mutations and we have higher variant allele frequencies in the supernatant than in the cellular pellet. This sounds paradox, but probably the lymphoma cells are so fragile that they die, release their DNA, and what remains are the reactive T cells and macrophages, which are more resistant and stay in the cellular pellet, and so we always have, and this has been in every single case. We have higher allelic frequencies so in the supernatant as compared to the cells, which shows that if you have a fluid which is in a restrained space, like the cerebrospinal fluid or the vitreous, or also other fluids. Whenever you have a fluid, you can do that. You actually have very good chance of detecting the mutations in the supernatant. And the question now, if we can do all this in fluids, why do we still need morphology? I'm going to give you a case which I saw recently, which goes beyond lymphoma, but I think it's a fascinating area, which is histiocytic disorders. And we got this as a consult case. And the pathologist told me, okay, well, the patient has a gum lesion which expresses CD1A and langerine, so this is Langerhans cell histiocytosis. But the patient also has this diffuse thickening of the retroperitoneum, and it has this, what you as radiologists, if there's a radiologist here, probably should know as hairy kidney sign. And he got a biopsy from this mass as well. And he said, well, this is pure inflammation. This looks like retroperitoneal fibrosis. You have lymphocytes, you have a couple of histiocytes. You also have a couple of histiocytes in the bone marrow. But he found a BRAF mutation not only in the Langerhans cell histiocytosis, but also in this inflammatory infiltrate. So what's this? Well, that's very simple. What is it? Well, this is a mixed histiocytosis. This is Erdheim-Chester disease with this classic retroperitoneal thickening. And the Langerhans cell histiocytosis, they share the same BRAF mutation. And this here, if you know histiocytosis, you say, okay, this fits with Erdheim-Chester disease. So you still need the morphology to put the things together, I think. And I could give you other examples, because a mutation alone doesn't give you a diagnosis. So many, especially of those which are in the same age group like myself, will probably have quite a few cells with the 14-18 translocation in the peripheral blood. 50% of people over 40 years have BCL2 rearranged cells in the peripheral blood. This doesn't mean that you have follicular lymphoma. This is a pre-neoplastic state, which in most people will never grow out to manifest lymphoma. That's why it's important not to just look at the molecular marker, but to look at morphology, at the clinical features, etc. So in summary, we still use clonality analysis, conventional clonality analysis, and single gene assays like FISH and hotspot mutations. They remain important. But I think NGS is going forward both to replace conventional clonality analysis as well as a tool for mutational profiling, because we need more information for subtyping of lymphomas, for example, the differential between BCL2 negative follicular lymphoma, marginal zone lymphoma, as an example, which you're working on right now. And we need it especially for relapse patients because especially in relapse, for example in DLBCL, you want to look at the molecular profile, which therapy might be more relevant and how is the risk profile of this patient. What's urgently needed, however, is standardization of pre-analytics of NGS panels of variant calling and interpretation, and that's what we are doing with ring trials in NGS-based mutational profiling in Germany, for example. Liquid biopsy is a way to go for follow-up and therapy response, and I think it's also a way to go for specific entities. So if you have a CNS lesion which you can't biopsy, I think the CSF is an ideal tool to do liquid biopsy for diagnosing DLBCL. We still will need morphology, and I think we will need the tissue still, because what I've not talked about is the microenvironment, the immune microenvironment and the immune response, which is, I think, a crucial part of how patients respond to therapies and how their prognosis is. And this you can only do if you look at the tissue under the microscope, even if you do multiple staining. So morphology remains the key for me to provide context to all these assays. With that, I would like to thank you. So I think I didn't take up too much of your time, so we can discuss a little bit. I just want to thank my co-workers, Irina Bonsheim from the molecular lab, all the people who were involved in some of the work I showed you, the people from Euroclonality, Itzia Salaveria and Elias Campo, with whom we have been working for many, many years, Vino Kakaseri, an ophthalmologist on which we're doing this work, and one of my mentors, Elaine Jaffe and Mark Raffeld at the NIH, which is currently destroyed, and especially my wife, who is also the reason why I talk some words of Spanish. With that, I would like to thank you. Anyway, I'm happy to take questions both in Spanish and in English.
Thank you very much for the comprehensive talk. Possibly we still have to do a lot of work right now, but good news is that you have this panel for diagnostic use, which is commonly a problem, the validation for clinical use of these panels of NGS. Mm-hmm. So the point is these panels need to be dynamic in a way, because the knowledge is increasing in years, so you need to incorporate new genes, new translocations possibly. So what do you feel about this?
Well, actually, we have evolved along the way. We started with small targeted panels for certain purposes. So, for example, our angioimmunoblastic T-cell lymphoma panel just has TAT2, which is already 50 amplicons because it's a huge gene, DMT3A, IDH2, and ROA. For B-cell lymphomas, we have a specific panel for BCL2 negative follicular lymphoma because that's our research interest. But now, as a working tool, we have a currently 70-gene panel for B-cell lymphomas. And of course, we have commercial 500-gene panels, which, however, don't include all the genes which we want. So we have the option to design a panel up to a certain size and add new genes without redesigning the whole panel. But this has certain limits. So you can say, okay, to these 70 genes, we can add another 100 amplicons or 10 genes, but that's it. Then we have to redesign it, make 2 pools, for example, and so on. So we're moving along. We are moving from small panels for specific purposes more and more towards the direction of larger panels. But we still use some of the small panels because they're very useful. So in angioimmunoblastic T-cell lymphoma, we don't have prognostic markers, but sometimes it's very difficult to make the diagnosis. And clonality is mostly positive, but you may have cases which have only a very minor clone. And so with these 4 genes, if you have a 1% ROA mutation, you know that's angioimmunoblastic T-cell lymphoma. So we're very pragmatic in this. We don't say, okay, we need these 200 genes or 500 genes for every lymphoma. We really cut to the purpose because this saves time and money. The small panel is done in half a day, the evaluation, or we just save time, and the turnaround time is easier. But in general, we move on from smaller to larger panels, basically. We are trying whole exome sequencing now, but we are not there yet. And this is one approach, since the prices go down, which we will probably move to, is to use whole exomes and use so-called virtual panels, which means you have the whole exome data and you look at this set of 50 genes in this whole exome, without also including copy number changes, without going forward and say, okay, I'll do the whole exome evaluation.
Okay, thank you for your talk. This is a question from an outsider, right? But it looks to me that, that you have, despite this beautiful example you gave at the end, you have a lot of genetic tools to diagnose the lymphoma in this case. So I wonder if the microscope has not been invented yet, you could still do a fair diagnostic based only, but you have easily available, transcriptomics and genomics, you still can do, you can handle with the diagnosis of lymphoma. And forget about pathologists. I'm sorry, hopefully I don't mean to often.
Well, I remember when I was a resident, I heard a clinician talk about breast cancer. He said, well, we'll do a fine needle aspiration of breast cancer, do a genetic profile, decide what to do with the patient, give the therapy, and that's it. Well, we still categorize breast cancer, still the most important prognostic features in breast cancer are conventional pathology and clinical parameters. And you still need to excise the breast cancer because chemotherapy doesn't get rid of it. Well, in some patients, yes, but that's only a minority, as you know. And so the same is true for pathology. I've always worked in molecular pathology, but I've learned more and more in morphological diagnosis and phenotyping through molecular. And that was what Elaine Jaffe once said. It's great to look at the microscope and an H&E slide and these cells have a BCL2 translocation. But you only can do that if you do the molecular studies and you correlate this. So we always go back to the slides. We published recently a paper which showed that all the angioimmunoblastic T-cell lymphomas which have IDH2 mutations have clear cytoplasm. So now we recognize, we can tell you this has an IDH2 mutation. But you need to go through this circle of innovation with molecular. And one thing is clear. So even if we do a 500 gene panel, for some lymphomas, you still need to look at the morphology and say, okay, to decide what it is. Hairy cell leukemia is a good example, yeah? Hairy cell leukemia has the BRAF mutation, but you know that B434 non-mutated hairy cell leukemia has MAP2K1 mutations, but the same MAP2K1 mutation you find in hairy cell leukemia variant. That's probably why the WHO has got rid of it. But you can find BRAF mutations and you can find MAP2K1 mutations in a range of lymphomas. Yeah? You can do a fine needle aspiration of a lymph node, and you can say, okay, I have a BRAF mutation, but you still don't know whether this is hairy cell leukemia. You will ask your flow cytometrist, please look at the phenotype. Yeah? So I think that's important. But I do say, I don't know what's going to happen in 10, 20 years from now. But morphology is still a very cheap thing to do, basically. But you need training. Yeah? But you also need training to interpret your molecular profiles. So if you do a ring trial and you send around the raw data, the FASTA files from NGS profiling of 10 different lymphomas, and you send it to 20 people, molecular biologists in Germany or in Spain, you probably will get 5 different diagnoses back. Yeah? So you have to use something which brings everything together. Morphology is a basis for that, but basically I say we are tissue experts. So we can bring all the different tools together, which is H&E slide or GIMSA slide in Germany, like to do that, immunohistochemistry, and so on, and molecular. But there are certain indications where I say, I'm a morphologist, but out of 100, we have now more than 80 lymphomas diagnosed in the vitreous. Of those, probably I would have diagnosed by morphology 10. Just to give you an example, because we see with molecular, we see so much more. So it always depends on the indication, on the material, etc. But I see a big problem. If we do smaller and smaller core needle biopsies, we end up with people not learning morphology enough. And then especially for the difficult cases, you don't have a molecular profile, this is this. Yeah? And if you look at follicular lymphoma and if you look at transformed follicular lymphoma, which look completely different and behave completely different, the follicular lymphoma and the transformed, very aggressive DLBCL may have exactly the same mutational profile. Yeah? You know that a TP53 mutated CLL is more aggressive, but you can have an MBL with TP53 mutations for 10 years and you will never need treatment. So you always have to bring the things together.
Thank you very much for your excellent talk. My name is Sonia. I work at the hematology department, treating patients with lymphoma. From my perspective, I would like to ask you, taking account the diverse nature of DBCL, which has a key barrier to improving first-line treatment, do you think it's time we include sequencing technologies into our clinical practice? What are, in your view, the main obstacles to doing this effectively?
Well, I would say I would like to do that, but it's a matter of cost and resources. And I think it's not necessary for every case, because if you have a conventional DLBCL, which is conventionally typed, and you don't have a double hit, for example, you know that many of these people will do well, and that much of the prognostic information comes out of the conventional IPI and so on. But I think that by doing mutational profiling, this doesn't have to be whole genome stuff, you know? Like, I know in Germany now, everybody, especially those who don't know a lot about it, will say, okay, we'll do whole genome, yeah? So this doesn't bring anything. But I think targeted sequencing will give us a lot more information, and if we look back, just the story of the pediatric type follicular lymphoma shows you how much impact that can give. And I would say that in our practice, and we have a lot of consult cases, so we have an abnormal distribution of more difficult cases. But I would say that we probably use NGS-based mutational detection in perhaps 10% of cases, no more, so that in a general practice, this would be less than that, but we would like to move on. Of course, we have research interests also, but I think there are certain indications where it would be very valuable. Aggressive B-cell lymphomas, which are hard to put. We all know the dark zone signature, which is like Burkitt, but doesn't have a MYC translocation and so on. So I think aggressive B-cell lymphomas in younger patients and also in elderly patients, MCD, probably it's worthwhile to do sequencing. Small cell lymphomas which are not defined easily, like follicular lymphoma with BCL2 translocation, marginal zone lymphoma versus follicular lymphoma BCL2 negative, splenic lymphomas, all the leukemic lymphomas which are hard to grasp sometimes, I think these should be sequenced. And this can be done with a targeted approach. So because, for example, we have a younger patient and he has a MYC translocation, but it looks like DLBCL. We do sequencing to find whether the patient has Burkitt lymphoma typical mutations like ID3, CCND3, TCF3, etc. Because that's important information, whether this patient has an aggressive DLBCL or whether it's a Burkitt lymphoma, which doesn't really look like Burkitt. So I think we will move there, but I don't think for good care of a conventional standard lymphoma patient, you need it right now. But I think there is a subset of patients which you really need it, which one group is the relapsed patients and the other group is the difficult cases. And I think for those, we really like to have that actually by now in diagnostics. Muchas gracias.